Good evening, viewers. Today I'll be presenting you before you all guys radioimmunotherapy and its clinical implications as well as the future prospects in India across the world as well. Myself, Major Dr. M. Kubeg from JK Cancer Institute, presenting you the radioimmunotherapy that is also called Zetotherapy. What is all about the radioimmunotherapy? What we are talking about is basically targeting and destroying the cancer cells with a radionuclide without damaging the nearby surrounding healthy cells. What basically we do here, actually the concept is the isotopes, radioisotope is combined with the antibodies against the cancer cells, and a chelator links the antibody to the isotopes, and then these antibody labeled with the isotopes, specific isotopes, recognize the cancer cells antigen and attack the cancer cells. And then the principal target here is the DNA of a cancer cells is get damaged because of radio label in isotopes. And we all know the cancer cells express a specific antigen, so that we make a specific antibody against that. So that is all the philosophy behind the radioimmunotherapy, that is Zetotherapy. So radioimmunotherapy is considered to be a fifth pillar of a cancer therapy, because we know the recognized cancer treatment is the surgery is well established, cytotoxic chemotherapy is very well established, radiation oncology is very well established, targeted therapy, immunotherapy is very well established. But the radioimmunotherapy, Zetotherapy is now considered to be fifth pillar, because here a team of doctors are involved here, like radiobiologist, physicist, nuclear medicine specialist, and radiation oncologist. All four peoples decide and then start the Zetotherapy. Though its prospects in India is very limited, very limited, but in across the world, and then some university like John Hopkins University, Baltimore, Dr. Order and all, they are practicing this kind of a radioimmunotherapy, rather making a high level research on this in a phase 3 trial and a meta-analysis regarding this radioimmunotherapy. So introduction, the antibody is directed against the tumor-associated antigen, provides a means of delivering the preferentially cytotoxic radionuclide to the primary tumor tissue as well as its metastatic site, that's known as Zetotherapy or radioimmunotherapy. So we are taking care of both from a primary tumor for primary as well as the metastatic site, and it's a directly face off, I mean, head to head, neck to neck competition with the treatment of like oligometastasis, SBRT treatment of oligometastasis versus Zetotherapy treatment. In coming future, there will be a comparative analysis between the both the treatment modalities. The important factor for radioimmunotherapy is that the factor can influence the effectiveness of radiotherapy in the tumor compared to its effect on a radiosensitive normal tissue depends upon the specificity of the antibodies. If antibody is very specific, so it will pick up only the cancer antigen, and that cancer antigen is only expressed on the cancer cells, so that exclude the normal tissue, normal cells, and the harmful effect of radioisotopes treatment can be minimized. Other factor which can influence the distribution of target energy in the tumor, and third is the host response to the injected foreign antibodies. So these are the factors which really make the base of a radioimmunotherapy. So here in this picture you can see the monoclonal antibodies especially designed against that particular antigen for against the cancer cells, and clubbed with the radioisotope with the help of a chelator. And now when they are injected, these radioisotopes along with the monoclonal antibodies as a carrier goes to the cancer cells and destroy the DNA. Double-stranded DNA damage is really required for the specific killing of tumor cells. A single-stranded DNA damage may lead to the, in the subsequent cell cycle, the repair. So the double-stranded DNA required. So you see here the same things on the in this picture, the radioactive molecule, antibody, and combined with and then a beam of radiation goes inside the cancer cells and markers on the cell surface. So does it only hit the cancer cells? Radioactive molecule must have a range of it's a range. So it cannot be controlled that it is limited to the cancer cells. What advantage we utilize of this radiation to the nearby area, I'll tell you in the subsequent slides. One should also know the parallel growth of a genetic engineering are geared towards the problem of reducing the antigenicity of specific antibodies, because we want a specific antibodies, but it should not that behave like an antigen for the tumor in the host, because if it is high antigen for a host, the the other antibodies start developing against this, that can create a problem, and as well as the reducing the mass of a cancer antigen antibodies. So radioimmunotherapy got a thrust after the development of new monoclonal antibodies as a part of chemotherapy immunotherapy for cancer treatment because of the three factors given below. One is monoclonal antibody introduction allows more precise targeting to cancer cells in compared to polyclonal antibodies, and an improved gamma and positron tumor immune imaging can obtain by the help of monoclonal antibody since it gets concentrated in tumor tissues. The second advantage. The third has been the number of research and studies indicates the definite clinical response to monoclonal antibody leveled with a radionuclide for the treatment of cancer cells. So what is basically targeted in radioimmunotherapy? The ultimate target is to administer the radio-labeled antibodies oblique polyclonal antibodies are basically produce the ionizing radiation to the DNA of malignant cells to kill the cells. The effect of radiation due to double-stranded DNA damage is not because of a single-stranded DNA damage, and it has been found that the low LET radiations are more effective in compared to the high LET radiation like alpha particle, and the beta particle like low LET radiations are more effectively controlled these radioimmunotherapies. One advantage of a target radiation has over antibodies targeted cytotoxin is that the tumor cell without appropriate antigenic determinants can yet be sterilized by the radiation, that is crossfire. That I was telling you in the previous slide, what happens that the tumor cells having a specific antibodies can only get a radiation? No, because there is a heterogeneity in the tumor. Some cells of cancer cells having antigens, some does not having antigens. So what will happen the nearby tissue, because of a crossfire, because extra radiation that is nearby cells will be killed by, because of or clonogenic cells will be killed by because of crossfire policies of philosophy of crossfire to the neighboring malignant cells. The sterilizing efficiency of a crossfire effect will depend to the large degree upon the spatial arrangement of the malignant stem cells in respect to the label carrier antibodies. Means the crossfire effect will more effectively depend upon the arrangement of nearby malignant normal cells along the malignant cells. The same things I am trying to explain you guys. So what are the antibodies? Basically, the antigen against that the antibodies is developed. These are specifically for breast and ovary, prostate, MUC1, breast, ovary, prostate, lung, colorectal, TAG72. Like for carcinoma and embryonic antigen against the antibodies is developed. that is more useful for lung, breast, and colorectal carcinomas. So these are the basically the gangliosides. GD2 is developed against the medulloblastoma. So these antibodies, monoclonal antibodies, are very very specific for the specific cancer type of a cancer cells. So what should be the ideal target? One ideal target for the radioimmunotherapy, one that is overexpress antigen on the cancer cells. These type of cancers do have a response with the radioimmunotherapy, and there has to be a number of receptors, like more than 100 receptors on each cell is required for adequate targeting. The antigen must be uniformly expressed over the cancer cells required to be targeted. Otherwise, what will happen? Resulting in non-uniform or heterogeneous dose distribution. Not when we are basically intended to go deliver the homogeneous dose distribution, but the homogeneous dose distribution required a homogeneous cancer cells distribution. But it is not the pick actually the scene. The radionucleotide should not shed into the blood circulation, because if it is gone in the blood, radionucleotide, and will get deposited in the kidney, and then will create a problems, and then some public hazard as well. The carrier of radio immunotherapies, that carrier basically we want to explain you that carrier is nothing but antibodies which is labeled with the radioisotopes. The purpose of antibodies to deliver the tumor cells sufficient radioactivity to sterilize or neutralize them. Attention must be focused on delivering a high level of radioactivity as quickly as possible to the tumor cells, because as much as a delay is there, there is a nearby tissue, normal tissue damage is there. Equally important, the retention time of radionucleotide in the tumor cells relative to the dose limiting normal tissue should be as long as possible. I mean, the retention time should be more in the tumor cells, more and almost negligible ideally to the normal cells. These are the properties of radioimmunotherapies, antibodies, carrier antibodies. You can see here the murine, carimic, humanized, fully human. So you see in the humanized, in the picture D, humanized monoclonal antibodies, they basically target the CD, means cluster of differentiation markers, so that if they are a CD specific marker, so that we can design the antibody against a CD specific, like non-Hodgkin's lymphoma is usually positive for CD19 and CD20. So if you have anti-CD19 CD19 antibodies, so it's more specific for tumor cells to kill this in that's why the hematological malignancies, they do perform very well for Zetotherapy. To maximize the ratio of a dose to the tumor cells in compared to the normal cell, ideally the physical half-life of a radionucleotide should be almost equal to the biological half-life of antibodies. But the problem is that the radionucleotide half-life is constant, it is not varies, it is fixed. But unfortunately, the antibodies biological half-life greatly varies depending upon the types of a tumor, which variety of a tumor is there. There may be the very fast disposal, very fast metabolism, and then a tumor is not biological half-life of antibodies will be different in different type of tumors. So that is the problem which I am trying to indicate you guys. The monoclonal antibodies more avidly bind to the tumor cells antigen in compared to polyclonal antibodies. That's already explained you guys. After the injecting the radio-labeled antibodies, immunogenic reactions happens. So that's why we tell that we should try to reduce the antigenicity of the antibodies as much as we can. Because after the injecting the antibodies, there is a immunogenic reactions happen in the host, and the immune complex is formed. These immune complex get accumulated in the host reticuloendothelial system, that's basically spleen, bone marrow, kidney, liver, and then certainly the bone marrow, if you get immune complexes deposited, it's very sensitive and may lead to the myelosuppression, TLC gets down, and the patient gets sick. Spleen and kidney is deposition is there. There may be a renal problem, renal toxicity, because they get stuck there in the renal globulars. So that we have to check this thing. We also know the circulatory tumor antigen are also present in the host blood. The philosophy of a liquid biopsy, if you can recall, that what we did, we take a blood samples, the serum basically, and we found the circulatory ctDNA or cell-free DNA and microsomal RNA, mRNA. So these are basically are in the blood. If suppose in a tumor that we know this thing, so if we give antibodies, they will combine before going to the tumor cells. It will combine the blood itself and then get deposited in the I mean that these combined with it, then they form the immune complexes and get deposited in the reticuloendothelial system, kidneys, and producing the harmful effect. Unfortunately, it remains a significant stumbling block in the treatment of radioimmunotherapy, which I am trying to tell you. There is a various publications, but the HHS Public Access International Journal, the Stephen M. Larson, George A. Carskelo, Non Kong V. Chung, Oliver Press, these scientists are working very at their finest level, and they published the paper on the 2015 June in the HHS publications regarding the radiotherapy for human tumors. So the other scientist working in the John Hopkins University, Baltimore, the Dr. Order, is working on this issue specifically regarding the radioimmunotherapy. So little bit about the physics and radiobiology of radioimmunotherapy. Delivers radiation to target tissue in continuous, although declining low dose radiation. So I mean basically the low dose LDR type of radiation is more suitable for radioimmunotherapy. The typical dose rate of radioimmunotherapy are in range of 10 to 20 centigrade per hour, and the total dose delivered by radioimmunotherapy is low in range of 1500 to 2000 centigrade with effective half-life of 24 to 72 hours. So radioimmunotherapy does appears to be effective where there is a inverse dose rate effect and retroactive synchronization. So dear PG students of a clinical oncology, you must open your book and find out what is the retroactive synchronization. So that is very important in the radiobiology, you should understand. And radiation-induced biological bystander effect, crossfire effects, these are the factors which appears to be very effective for radioimmunotherapy. So you see increasing the LET radiations, increasing the LET is basically the surviving fraction of the cells are, I mean, the optimum dose is not getting by the tumor tissue, and then the unnecessary extra radiation goes to the normal tissues. So the LET optimum low LET radiations are more suitable for in compared to the high LET radiation for radioimmunotherapy. So what are the radionucleotides which you see that we use the radionucleotide which are beta emitters, like what beta emitters preferably, because the beta emitter electrons having a path length, that is the wavelength in tissue from 0.6 to 12 millimeter and range approximately 60 to 1100 cell diameters. The most commonly used beta emitters are Yttrium 90Y and iodine 131. The iodine 131 is well researched, well utilized, so more commonly it is used as a radioisotopes. The alpha emitter is not basically used because of high LET radiations and unnecessary killing the normal tissue cells nearby the tumor cells, so that it is not suitable. But 211 astatine and 225 actinium is used here in the as a alpha emitters. And though it has a short range, the alpha particle very destructive and with a high LET radiations, and because of a high LET radiation, the range becomes limiting factors regarding this. The agar emitters such as iodine 111 and iodine 125 are more effective if delivered to the nucleus or the cells incorporated to DNA. Presently, RIT having a two clinical viable options so far as a clinical practice, one for hematological cancer, another for solid cancer. The major advances in radioimmunotherapy occurred with the hematological malignancies, and more encouraging results are there, like studying the report, the fractionated dose regime using iodine 131 anti-HLA antibody achieved remarkable regression of a bulky mass in non-Hodgkin's lymphoma. So, subsequent trials reported the iodine 131 labeled anti-CD37 antibodies, anti-CD20 antibodies, and anti-CD20 antibodies in lymphomas. So in all instances, RIT was limited by hematological toxicity because of a radio-labeled antibodies cleared slowly from the blood, exposing the radiosensitive bone marrow to a continuous low dose of radiation, leading to the myelosuppressions. When the dose was escalated to myeloablative levels with the help of bone marrow grafting, a significant number of patients achieved complete and objective response for extended duration of a radioimmunotherapy. So there are actually two recognized radio-labeled antibodies, 19Y and a 131 labeled anti-CD20 antibodies, now known as 19Y ibritumomab and iodine 131 tocilizumab, are the only radio-labeled antibodies approved in the USA for Zetotherapy. The above treatment is recommended for the patient those have less than 25% bone marrow involvement, because radioimmunotherapy, if a patient is having a tumor, hematological malignancies with bone marrow involvement, Zetotherapy is not probably useful because it will lead to the severe myelosuppressions. So that's a message we want to convey you guys. The radioimmunotherapy for solid tumors did rarely progress beyond phase 1 or phase 2 trials because the most of the trial failed to meet accepted criteria of an objective response. And however, two agents did proceed more advanced clinical testing for solid tumors, but at present we do not have any very very concrete meta-analysis of a radioimmunotherapy in a solid tumor till date. So, some intravenous injections in the solid tumor of the ovarian cancers is delivered for malignant ascites